Hello and welcome to this lesson, Invasive Ductal Carcinoma. So first, let's understand what is invasive ductal carcinoma. Invasive ductal carcinoma, which is also known as infiltrating ductal carcinoma, is one of the most common breast cancers, and it is accounting for 2/3 of all breast cancers that's happening. So here in this picture, you can see a normal duct structure, which is having a lumen, which is covered by epithelium, which is the innermost lining of the duct, and after that we have a supporting myoepithelial layer, and after that we have a basement membrane which is covering the whole structure. So in case of invasive ductal carcinoma and ductal carcinoma in situ, we have cancerous cells that are originating from epithelium of the ductal system. But the difference between invasive ductal carcinoma and ductal carcinoma in situ is that in case of ductal carcinoma in situ, the cancer cells are confined within the duct structure and they are not going to invade the basement membrane. But in case of invasive ductal carcinoma, we have invasion of the basement membrane, and as the result, this is how the tumor can have a very good potential for metastasis and malignancy. So another point is that, again, because of the fact that the tumor cells are invading the basement membrane, the ductal carcinoma, invasive ductal carcinoma, can spread to the nearby lymph nodes and causes metastasis, distant metastasis via lymphatic system. Another point about the metastasis of invasive ductal carcinoma is that because of the fact that the cancer cells are invading the basement membrane, they have access to the blood system and blood vessels. So another way to have a distant metastasis in case of invasive ductal carcinoma is via hematogenous spread and bloodstream. Now, what are the presentations in case of invasive ductal carcinoma? We can have a palpable mass, and the mass is going to be hard, irregular in shape, and non-tender in nature. And if the mass is immobile, if the mass is not moving through the breast tissue, it means that the mass is attached to the surrounding tissue of the breast. We can also have skin and nipple changes. We can find a dimpling of the skin, retraction of the skin, and also thickening of the skin over the tumor area. We can also have nipple retraction and nipple discharges, and note that the nipple discharges can also be bloody. Another point, another presentation of invasive ductal carcinoma is axillary lymphadenopathy, the lymph nodes in the axilla which are draining the lymph from the breast. Most of the lymph from the breast is going to drain in the axillary lymph node. We can have enlargement of the lymph nodes, and as the result, the lymph nodes in the armpit are going to be enlarged, something that you can see in this picture. And this is a very warning sign because it means that we have a local spread of cancer cells. But invasive ductal carcinoma can be almost completely asymptomatic and be found on routine examination and mammography. So what are the diagnostic tools that we can use? First of all, we can use clinical examination. You are going to see a firm and irregular mass in the breast, and this mass can be with or without skin and nipple changes. The imaging studies that we can use is mammography, and this is a very good test because it has a very characteristic appearance in the mammography. We can have a star shape irregular mass in the mammography, something that you can see in this picture, and also the tumor can have microcalcification, which you can see here and here in this picture. And also another point, another imaging study that we can use is ultrasound, and the ultrasound is going to show you a hypoechoic irregular mass lesion, something that you can see here. As you can see, the mass is irregular, and also the posterior acoustic shadowing can be visible in the ultrasound. So this is the ultrasound, and this is the posterior shadowing of the tumor. MRI is very useful if we have complex cases or when we have multifocal diseases. Another diagnostic tools that we can use is biopsy, and core needle biopsy is one of the best tools that we have, and it can confirm the diagnosis of invasive ductal carcinoma. And also core needle biopsy helps us to detect the presence of the receptors for this tumor, which we are going to discuss in the following slides. Fine needle aspiration has a very limited role in case of invasive ductal carcinoma because of the fact that the sample that is fine needle aspiration is taking is not enough to detect the architecture of the tumor, but it can confirm the malignancy in case of invasive ductal carcinoma. Now, what are the histological features of invasive ductal carcinoma? First of all, we have two main features that you have to know for your board examination. We can have infiltrative ductal pattern, and what you are going to see is ductal cells that are arranged in irregular clusters or cords, and these clusters are going to invade the stroma of the breast. Also, we can have desmoplastic reaction. Desmoplastic reaction is when we have a fibrotic creation of the fibrotic tissue in response to the metaplasia and dysplasia that happens in the tumor cells, and this causes hardening of the tumor cells. About the grading, you have to know 3 grades for invasive ductal carcinoma, and this grading is based on differentiation of the cells and also growth pattern and growth rate of the cells. So we have grade 1, which is a well differentiated cells, and we have very slow grade growth pattern. We have a grade 2 or intermediate grade, which is a slightly less differentiated cells, and we have a little bit rapid growth. And in the 3rd grade, we have poorly differentiated breast cells. We have fast growing cells with high malignant potentials. So here you can see the difference between normal ductal system, ductal carcinoma in situ, and invasive ductal carcinoma. As you can see here, we have epithelial cells, myoepithelial cells, and we have basement membrane in normal ductal system of the breast. Here you are going to see the cells that are originating from epithelial cells, but they have not invaded the myoepithelial cells and the basement membrane of the ducts. And here, in case of invasive ductal carcinoma, you are seeing cancer cells that have invaded the basement membrane, and myoepithelial disruption also can be seen in case of invasive ductal carcinoma. Now let's talk about the receptor status in case of invasive ductal carcinoma, and this is one of the most important information that you have to know for your board examination. So invasive ductal carcinoma can have 3 types of receptors on its surface. We can have estrogen receptor and progesterone receptor, and this is a very good news because if the tumor is positive for estrogen receptor and progesterone receptor, we can use hormonal therapy in order to slow down the growth of the tumor. We can also have HER2 receptor, which is human epidermal growth factor receptor 2, and this is actually also very good news because the overexpression of HER2 receptor is indicating the aggressive behavior of the tumor. But these tumors who are positive with HER2 receptor can be targeted with targeted therapy with trastuzumab or Herceptin, which improves the outcome of the disease. The bad news is when we have a triple negative tumor, which is negative for HER2 receptor, estrogen receptor, and progesterone receptor, and lack of these 3 receptors actually causes a little bit less favorable prognosis and more aggressive behavior of the tumor. So what are the staging? The staging that we can use for invasive ductal carcinoma is the classic TNM. T stands for the size of the primary tumor, N is nodal involvement, and M is for metastasis. Of course, the tumor can be in different stages. We are not going to talk about the different stages in case of invasive ductal carcinoma. But note that if the tumor is in a stage 0, it means that we have another disease. We have ductal carcinoma in situ, and stage 4 means that we have a metastasized disease with cancer cells spreading all over the body. So now let's talk about the treatment options in case of invasive ductal carcinoma. So we have 2 surgical options. We have lumpectomy, which is a breast conserving surgery, and this is done usually for low-grade tumors, and when we have a clear margin between tumor cells and normal cells of the breast. We have another option, we have mastectomy, which is when we have the entire breast removed from the body, and this is usually done for large tumors or when we have a multifocal tumors spreading all over the breast. Addition to that, you have to do the sentinel lymph node biopsy in order to assess the lymph nodes and see if there are local metastases to the axillary lymph nodes or no. We have adjunctive radiotherapy, and this is usually done with lumpectomy or mastectomy, and this is actually done in order to reduce the recurrence chance of the breast cancer. Chemotherapy also can be used, and this is usually reserved for large tumors or high-grade tumors, and when we have involvement of the lymph nodes, or when we have a triple negative breast cancer, if the breast cancer are negative for estrogen receptors, progesterone receptors, and HER2 receptors, we can use chemotherapy in order to increase the survival rate of the patient. So hormone therapy can be used, and this is used when we have a progesterone and or estrogen receptor positive tumors. We can use tamoxifen for pre and postmenopausal women. We can also use aromatase inhibitors for postmenopausal women who are positive for estrogen receptor and progesterone receptor. We can use targeted therapy with Herceptin. This is used when we have HER2 positive tumors, and this is sometimes combined with other agents in order to increase the efficacy of the treatment in case of invasive ductal carcinoma. Now, what are the key points for exam? First of all, note that invasive ductal carcinoma is one of the most common breast cancer, invasive breast cancer that we have. This is usually found incidentally on routine mammography and ultrasound, and the tumor can have three receptors: estrogen receptor, progesterone receptor, and HER2 receptors, which is affecting the prognosis and treatment plan quite greatly. And invasive ductal carcinoma tumor usually presents with hard, irregular, and immobile mass in the breast. Thank you for watching.